It is a pleasure to be here. I remember I was impressed many years ago when I was in this unique setting, and I'm even more impressed now. So it's beautiful. And as a rebuttal to Michael, I think the beauty is to keep tradition and at the same time be at the frontier of knowledge. And in many countries, we don't do that. So this is excellent. So, the topic here is basically the whole meeting. I just want to emphasize that there are two major papers that address the whole issue that we are dealing today. One is the third report of the consensus group, and more recently the ARC document, which is being just published, summarize all the information we got on this challenging topic. Now, classically, there are two lesion subsets that are always differentiated, which is ISR and the novo Lesions. So let's go for ISR. As you can know and remember, the last revascularization guidelines for the European Society of Cardiology gave a 1A indication for the use of either drug-eluting stents or drug-coating balloons for patients with either bare metal or drug-eluting stent restenosis. That was very clear based on evidence, and they also recommended the use of intracoronary imaging. There was a consensus in these patients. So the whole field started after this seminal work by Bruno Scheller, which has been everywhere. But remember, there is only 52 patients eventually randomized, but the effect of the paclitaxel-coated balloon as compared with the POVA was so dramatic that there was a major difference, as you can see here, in lay loss and also in binary restenosis rate. 10 years ago, we published this study in JACC, and this is the RISC-4 studies, where the RISC-4 study where basically patients with drug-eluting stent restenosis were randomized to everolimus-eluting stent or to paclitaxel-coated balloon. So we demonstrated at the time that the initial superior results obtained with stents were maintained at follow-up, as you can see here, and this translated into superior clinical outcomes. The same angiographic benefit was also evident, that was RISC-5 in patients with bare metal and stent restenosis, but the clinical implications were not so clear. So the definitive answer to that came from this study by Adam Castrati, which is the Daedalus meta-analysis. This is a patient-level meta-analysis, including 10 randomized clinical trials, nearly 2,000 patients, where the main results suggested that target lesion revascularization and clinically driven target lesion revascularization was reduced with the use of drug-eluting stents as compared with paclitaxel-coated balloons. So this is the Kaplan-Meier curves. You can see the superiority of stents in this regard, but this superiority mainly concentrated in patients presenting with drug-eluting stent restenosis, and no clear benefit was seen in patients with bare metal and stent restenosis. So this is an important point. And the other issue is regarding safety. And as you may see here, there is a signal that was not significant for a higher risk in patients treated with a second stent layer. However, again, there was an interaction, and the risk was confirmed by first-generation drug-eluting stents, and no risk was detected when paclitaxel-coated balloons were compared with second-generation drug-eluting stents. So this is a very nice image from J.J. Coughlin, and you may see here that currently there is a major interest in the use of drug-coating balloons in patients with stent restenosis. All those studies are randomized, and in light blue, you can see when the studies got a DCB arm. So in some way, there was a surprise. The last European guidelines on chronic coronary syndromes where they emphasize this different approach, so that the sentence is exactly that when we are facing a patient with drug-eluting stent restenosis, this should be preferred over DCB, and this is a 1A indication. So I think the wording is very important because, this appears to be a very strong statement, drastically different from the prior information. And I'm pretty convinced that we all agree that there are many situations. Target lesion revascularization from Daedalus is not the only thing that matters. perhaps patients with bare metal in-stent restenosis, patients presented with the first in-stent restenosis, so we can use a stent if the patient is coming back, patients with multiple metal layers, those with resistant under-expansion, when we obtain an optimal result after predilation in patients at high bleeding risk and in patients with major side branches. At least these scenarios appears to be a good niche for the use of drug-coating balloons. In the same paper, we emphasized the importance to assess the type of lesion we are facing in in-stent restenosis, the importance of lesion preparation, and finally, we need to decide which is our final treatment, a drug-eluting stent or a drug-coating balloon. And in every single of these steps, the use of intravascular imaging is key for improving results. This is a very old slide emphasizing how under-expansion is a major mechanism still in the drug-eluting stent era of in-stent restenosis. However, if you want to analyze the tissue obstructing the stent, OCT is by far superior. You can see here a typical example of neointimal proliferation, this bright, healthy tissue within the stent. In some cases, you can see neoatherosclerosis. You can see the lipid shadowing the stent struts. And in some cases, you can even identify calcium within the stent, calcified neoatherosclerosis that sometimes is very difficult to treat. And in this regard, there is a nice study which is running so that the question is whether or not the type of underlying tissue could affect the relative efficacy of drug-coating balloons versus drug-eluting stents. This is our desired file. Now, very quickly, data regarding the novo lesion that is becoming more trendy. So the first study with power for clinical events was this basket small 2 trial where drug-coated balloons demonstrated to be superior to stents, first generation and second generation stents at the time in patients with a small vessel. So this is important because it's power for clinical events. Also, there are other clinical situations. You can see here patients at high bleeding risk where avoiding the implantation of a new metal layer can be of major value, and this is also intense research in this regard. And at the time we performed this meta-analysis, putting together all the randomized clinical trials, comparing drug-coating balloons versus alternative strategies in patients with de novo lesions. 14 trials, 2,500 patients, and you can see here how there was no difference whatsoever regarding target lesion revascularization. There was also no difference regarding the type of indication. And when we compare only DCBs with drug-eluting stents, again, there was no difference in target lesion revascularization. Now, the issue is that there was another trial. This is cage-free, one where in the novo lesions, non-inferiority was not met, relatively simple lesions, I will say, but there is a clear interaction regarding vessel size, as you can see here. So in this new meta-analysis by Robert Byrne, you can see that including patients in cage-free, again, when the two strategies are compared, and this is data coming only from randomized clinical trials, the main outcomes and the individual endpoints are similar in the two strategies. This is also a very nice paper by Bernardo Cortese. This is including patient-level data of 4 randomized clinical trials with more than 3 years of follow-up, so long-term follow-up, comparing drug-coating balloons with drug-eluting stent in small vessels. And you can see here that there was a benefit regarding MACE in this large and recent meta-analysis. Now, in San Francisco, we learned the new evidence that was quite impressive. Again, the solution de novo primary endpoint was released at 1 year, and you can see that regarding target vessel failure, the risk difference after 1 year was less than 1%, and that met, obviously, the non-inferiority margin that was pre-specified in the trial. This is the components of the primary endpoint. Perhaps there is an increase in clinically driven revascularization with this novel drug-coating balloon, but the clinical implication should be determined. And I will finish to say how this is affecting our practice. Well, this is a classical slide on the data some years ago on the use of DCB in the prediction. So in this slide, there was a prediction that 1 out of 10 PCIs in 2030 will be performed using DCB. Let me show you the data in Spain. In Spain, the number of stents and the number of intervention requiring a stent are in a plateau. This is not growing. In fact, it's slowing down a little bit. And the number of procedures where a DCB is used, either as a hybrid strategy or as a DCB-only strategy, are increasing dramatically. This is the change in all our regions. In Spain, you can see there's a major change, and altogether, currently, this is data from this official Spanish registry, on PCI from last year. And you can see that 14% of all PCIs in Spain now involve the treatment of at least one lesion with a DCB. So thank you very much for your invitation.